some progression. And I just want to say, Connie, you got this.
Oh, hi, Connie.
Hi, Connie. We got you.
My name's, excuse me, my name's Larry. I was diagnosed in January of 2013. My friend Jane and I were diagnosed the same week. And we've known each other for 30 years, maybe more. But anyway, I'm glad to be here next to Jane tonight.
Like you two.
I was diagnosed with non-small cell adenocarcinoma, stage 4. My first round of treatment was chemo. Did that for a year. Then I went on chemo holiday for a year. And then in January of 2015, I progressed. I started on Tarceva, and it lasted for 20 months. And when I progressed on Tarceva, I had the T790M EGFR progression mutation. So I started on Tagrisso. And this month, I will have been on it 3 years. And my scans are good, and I'm happy to be here tonight.
Thanks, Larry.
That's an amazing response.
Hi, my name is Rick Meyer. I have stage 4 non-small cell lung cancer. First diagnosed in November of 14, so coming up on 5 years. That's pretty exciting. I'm ALK positive, so I've been through crizotinib, X396, which was a trial, alectinib, which unfortunately didn't work particularly well for me. Great for a lot of people, though. And now I'm on brigatinib. Decent scans. No NED, but decent scans. Dr. Neal's awesome. He's my quarterback in this whole thing. He's definitely keeping me around and happy. So I'm very happy about that. And looking forward to now going for 10, since we're going to get 5 done.
Thanks, Rick.
Do it, Rick.
Do
It's
it.
Rick and Rick.
Hi, I'm Rick Bryson. I was diagnosed in February of 2015. I was a never smoker. I went in for a different ailment and ended up getting an X-ray that led me down the path that I had stage 4 adenocarcinoma. I didn't have any of the genetic mutations, so I went straight to chemo.
Still no.
I did chemo for a year. I had some surgery and some radiation in there. But in February of 2016, I ended up having a clean scan, and they've been clear ever since. So I've been NED for 3.5 years now, and happy to be around, happy to come to a support group like this that gives me so much information about next steps and new developments, and it's really important to be here.
Thanks, Rick.
Thank you.
Wait, you're not going to talk? Oh, if you want to. I brought representatives of my posse with me.
Posses are awesome.
Hi, I'm Christina. I'm Tina's daughter-in-law. I actually didn't know Tina when she was first diagnosed. It was in 2010. I've lost actually 2 grandparents, great-grandparents, though, to lung cancer. My grandmother is currently a survivor. She had a lobectomy in 2012, and on top of that, she has non-Hodgkin's lymphoma and multiple myeloma, and she is just living life. It's great, but it's a thing. It's hard for me to say, but it's just cancer. It's been around everywhere, and then to see this woman killing it too, I'm so happy and thankful for all of the level of care and support she's getting. So they didn't have that for my great grandparents then. So yay.
My name is Tina. I was diagnosed in 2010, stage 3B. I had chemo and radiation, and then my fine doctor said, why don't we just go with the Tarceva for insurance? I had already tested positive for EGFR, and we knew that I responded to it. So that was, he said 1 year, I think, and then the next year, well, maybe another year would be good. And it's been 8 years on Tarcivas, so I don't really know why it's working, but I'm pretty happy about it.
That's right.
I think
right.
I do. Do you want? You don't have to.
I'll just cry, but I'll try. Really happy that you're here. I know that you played a big role in the journey that we've all been on, so thank you.
My name's Diana, and I was just diagnosed with lung cancer about 2 months ago. So I've gone through 3 chemotherapies, and I've responded very well. And I want to thank Danielle and Sally and Rosalie, for supporting me and connecting me to Stanford, Dr. Pata. Yeah. And so they're looking more into, my biopsy and the features of the cancer. And so anyway, I'm doing very well compared to before chemo. So yeah.
I'm so glad you came.
And I'm Rosalie, and this is our first night here, so we're really glad to be here.
Hi, my name
Welcome.
is Teresa, and I was diagnosed in 2017, June of 2017, stage 4 adenocarcinoma. I had a 16-centimeter tumor in the mass in the right lung, and I was put on crizotinib without chemo, and I had a pathologic complete response. After 3 months, it shrunk to about 60% of the size, and then after 8 months, they did a pneumonectomy, the right lung, and then the pathology report showed no signs of cancer cells, so that was really good. And so I kept on crizotinib, and then I stopped in May, and then the last scan showed some nodules in my chest wall. So, and then it tested positive for cancer. It was, I don't know if the nodules are also met exon 14, but I imagine. And so I will be undergoing radiology treatments next, and we'll see. But I felt really good the whole time with crizotinib, so that was always the very positive thing.
My name is Fred Palmer. I was diagnosed with non-small cell lung cancer in October of 2013. I was on treatment with immunotherapy until September of last year. I've stopped the treatment, and so far there hasn't been any sign of progression. Things are stable. And I'm also part of a clinical trial that's being conducted by Natera for a means of early detection of progression through blood specimens. So we'll see how that turns out.
Thanks, Fred.
Good evening. My name's Keith Perry, and this is my first time here. I was diagnosed with non-small cell lung cancer almost exactly a year ago, and so it's a bit of an anniversary for me of sorts. It was stage 2B, and it was in my left lung, largely because of the location. We had to do a full left pneumonectomy. And like many of you others, I went to the doctor for something that I didn't expect, and came out with this. We followed that with 12 weeks of chemo. Dr. Neal and I have known each other for almost exactly a year now, and I'm currently on a cycle of nivolumab for a clinical trial, and we're doing that for a year, and we're going to see how it goes. So my scans have been good, so we're moving in the right direction.
That's awesome. Welcome.
That's great. That's great.
Hi, my name's Angie Wilson, and I work at Genentech in patient advocacy. I'm a huge personal fan of everything Adario, lung cancer, GoTo, etc. And
Whatever.
Just happy to be here tonight. Thanks for having me.
Hi, my name's Wayne. I'm here tonight with Rebecca and her family, Chloe, her father Dennis, and Mother Nellie.
No puppy. Where's the puppy?
And puppy here.
Okay.
We're going to keep the Dr. Neal Love Fest going here. Rebecca was diagnosed.
I didn't plant everything.
Yeah. I want you to come, and this is what you have to say.
Rebecca was diagnosed in November 2017. She has stage 4 mucinous adenocarcinoma, KRAS G12D, no PD-L1 expression, and she was a never smoker. Dr. Neal became our care, took over our care after her chemoradiation, and he's been with us for about 1.5 years. He's totally awesome. And sadly, we had to leave him because there was some progression, and we went and pursued a clinical trial. And the clinical trial involves a drug called trametinib and Keytruda. And Rebecca took about 2 cycles of trametinib and 1 cycle of the Keytruda, and she had some really bad side effects. In fact, she got hospitalized because she had a lot of mouth sores that made it impossible for her to eat or swallow. And so we're going to do some scans and check and see whether or not the treatment's effective before deciding whether or not to continue. And so that's the cliffhanger that you guys have to, to wait for the next time.
Thanks, Wayne.
Thanks for.
Hi, my name is Karen. I actually am an 11-year survivor. I was an accidental finding, and I was stage 1B 11 years ago and had the upper left lobe removed and went through 4 cycles of platinum chemo. And at this point in my life, I just want to support this organization as much as I can. I hope to see a lot of you on Sunday because I think it's going to be an awesome event. And whatever we can do to bring more hope to people and help this organization bring more hope to people, we want to do it. Thank you.
Thanks, Karen.
Hi, I'm Jason. I'm a lung cancer advocate, so I'm super happy to be here, and your stories are very empowering to me. So thank you so much for sharing.
Hi, I'm Eric, and just returned from Barcelona from the International Association for the Study of Lung Cancer, and I was there with 7,562 of my friends. It was a big meeting. So I learned a whole lot, but I'll tell you 3 things that happened or that stuck with me, and that is that I learned that I didn't really know before, and that is cancer is not binary. And that's kind of weird. It's not like being pregnant. It's not you have it or don't. There's kind of a gray area, especially in the stage 1, where maybe you have a little bit, but maybe you don't. And then it kind of progresses. And that's something as cancer patients or survivors, we don't always think about. 2, cancer is tissue type agnostic, which means some of the genes manifest themselves in different tissues, but we call it lung cancer, and other cancers have the same gene deficiencies, mutations, problems. And along with that is not all of the targeted drugs will transfer so they can use the same drugs for the same problems in different cases. Not all of them. And so just doing research on any one cancer, lung cancer or others, transfers to all the other cancers, and that's kind of hopeful. And number 3 is over $1 billion is spent on cancer drugs a year, including research and everything else. 74% of that money goes to drugs that do not cure patients. So we spend $74 billion without giving a single person even 1 extra day of life. That's weird. And then on top of that, we don't spend even 1/4 of $1 billion for early detection screening, and that has to change. So that was one of the subjects that came up and kind of struck me. That much money is spent without helping when $250 million will find a lot of early cancers that can be fixed. So those are the three things I learned.
Thanks, Eric.
I have to tell you, though, these two beautiful people right here, I was at World Lung as well, and I was a discussant on the very last day, in the very last hour of the entire World Lung, and I thought no one is going to come to this session. They all left at noon. They're done. They're on their way home. And who was in the first row? These two friendly faces, just clapping away. So, thank you. We did have a couple extra people, but.
Hi, everyone. It's my first time here. I'm Lindsay. I'm from Genentech, and I just wanted to say thank you all so much for sharing your stories.
Evangeline.
Thank you. Good evening. I'm Evangeline. And first of all, I'm proud to say that the guest speaker now is my ever charming oncologist, Dr. Neal. Since day one, I met him with tears or no tears. He always gives me a hug when he comes in the clinic and upon leaving. So it boosts up my morale, especially with me not having a family around.
You have a family?
Yes, this is my family, and I found a family who are very supportive, and it really changed my perspective in life, because when I haven't found this family, I was always depressed and looking for answers why I got this disease. And so I'm very thankful for having found this foundation. And I have to give credit to the social worker in Stanford, Jenny Bosch, who encouraged me to join this foundation. Anyway, I was diagnosed by accident with stage 4 non-small cell lung cancer, adenocarcinoma, when I applied at Lucille Packard Children's Hospital, and they required a chest x-ray. So they found I had a mass on my upper left lobe of the lungs. And that's when I found out. And so I underwent series of CAT scan and then biopsy, and that's when it was confirmed that I have the lung cancer. And so I was supposed to have a lobectomy, and day before the surgery, I had an MRI, and it was discovered my cancer metastasized to my brain. I have 2 tumors, one on my left brain and the other is on the left bone of the skull. And so I was referred to Dr. Neal to be my medical oncologist. And since then, he's supervising I am EGFR positive, so I'm on target therapy. I started with Tarceva, and after 20 months, it didn't work. So I have to undergo biopsy, and now I'm on Tagrisso, which for now, it's the best thing that ever happened to me, because the Tagrisso is more comfortable for me, less side effects. And after 3 months, Dr. Neal and I were so thrilled. It was working on me because the tumor on my my right brain is now unmeasurable. It means that it decreased, and the tumor on my left lung has decreased by 1 centimeter. And so my next MRI and CAT scan will be next month, and we'll hope for the best, and I pray that it will be good news again for Dr. Neal and I.
Yeah, that's great. And you know, what she's talking about, too, is that her first drug didn't cross the blood-brain barrier, and this one does, which is a good thing. I'll explain to you later.
I'm Pat Pritchard, and I was diagnosed with stage 1 lung cancer, different kind in each lung. in November. So the day that I was diagnosed, I came here. And I've been coming each month. I want to support all of you. You've given me hope. Hearing 10, 11, 5 years, it's wonderful. I try to do, since I'm doing radiation every 3 months, I try to do something every day, physically and mentally, for my health. So I will see you on Sunday, and I'll keep reading.
Okay,
Thank
that's
you.
awesome.
Thanks, Pat.
We've ordered sunshine.
We're from Oncocyte. It's a molecular diagnostics company based in Alameda. We're really committed to developing diagnostics for the early detection and management of lung cancer because we recognize that that's when it's most treatable and the outcomes are the best. We've long admired the Adario Foundation and really looking forward to partnering with you.
And I'm Ryan Andrews, and I work for Padma.
Hello, I'm Nicole Stone. I'm also a Dr. Neal fan over here. I was diagnosed September 1st, 2018, and so I just went over my 1-year mark. Was diagnosed with non-small cell adenocarcinoma, stage 4. It was also hereditary, so I get to figure out what that means for my children. That's a later date. Let's see, I was on October, the following month when I was diagnosed, I had a tumor removed from my brain and was on Tagrisso for about 8 months. And then, surprise, we needed to come up with another option. So I started chemo, and I just finished my 3rd round. 3rd round was really hard and difficult for me. So we're hoping that next round we might not do the carboplatin, and let my blood counts come back up, and then go back on carboplatin once I go to round 5 or whatever. Let's see. I think that's all about me. Happy to be here and love this organization. So thank you.
Hi, I'm Patty, and I'm Nicole's friend. And we have more than just one child, but we happen to have 2 teenagers that have gone through our elementary school and now in high school together. And Nicole was very supportive of me on all the school functions that Nicole is known for doing. She's a very generous and wonderful person and was always there for not just for anything related to the school. If they needed something, Nicole volunteered. So I was lucky to have her volunteering for many of the things that we did together. So she's a very dear person. And I'm amazed to be here. It's very, very wonderful. And Dr. Neal, you're obviously very special. Yeah.
We're going to make him a little PSA just with all the comments
right,
on
right,
loop.
right.
You can play it in his office.
We're hiring him and putting him in marketing.
Hi, my name is Ranlong, Joe. This is my wife, Yan. I was diagnosed squamous cell stage 3 back in November 2014. And at that time, I met our best and most important friend, Dr. Neal. And he has been taking care of me since then. I went through 3 rounds of chemo. After that, I went through the surgical procedure. So ever since, I have been doing the CT scans every year. So I only see Dr. Neal at the moment once a year, except today I will be able to see him the second time. Very glad to be here. And my wife has been skipping this living room, only me coming, but she has been giving excuse not to come because it's too busy with work. And I said, can you be more busy than Dr. Neal? Then she has nothing to say but to come. So anyway, Dr. Neal, I like your haircut. It's just like my, when I was 20-year-old, I'm so jealous with you.
Yay.
I can't imagine a doctor, oncologist working with a cancer patient and their caregivers be so happy with their doing their job and so much achievement and day in, day out, she looks so young. I was so happy for him. And thank you for everything you do for all of us. Thank you.
You're welcome. And thanks for coming in.
I saw Joanne sneak in. I don't know, can we grab a...
While you're switching gears, I remember the night he walked in here when he first found out he had cancer. I don't know if it was you that
Right
told
here.
him or somebody else. He sat over there. And
maybe he did.
he just completely broke down and said he went and saw his lawyer, and he didn't. We said, no, just calm down, slow down. Slow down. Do you remember?
Yes. It's okay.
Yeah.
That's great. Go ahead, Joanne.
Okay, we had some grandchildren duty, and I thought we would miss this part. So let me see if I can get my thoughts together. I was diagnosed stage 4 in September 2016. So this month, next week, it'll be 3 years since my diagnosis. And I always repeat that was after a whole year of misdiagnoses of a cough. And I hope all the research, et cetera, is going to move us past that for anybody. It was EGFR, the mutation, went on Tarceva successfully for 2 years. And just at the point, actually, that Tagrisso was approved as first line, it became my second line. I had some progression, and it was T790M. I think I got that right. Anyway, and that has been for a year now, actually a year at the end of this month that I've been successfully on the Tagrisso, and so far, so good. I am a part of actually it was Natera's research study, which is for the blood biopsies to detect lung cancer progression, and others also, but in my case, lung cancer progression. That has now become commercial in a limited way, and I've been moved over, and I'm expecting a new blood draw next month, and now results within about a week or two, where it has been about a month in the research setting. But so far, it's been 0 circulating ctDNA since I've been on the Tagrisso.
Thanks, Joanne.
Look how smart all these patients are.
Isn't that the truth?
They're almost
Isn't that the
as
truth?
smart as Dr. Neal.
Thank you all for sharing your stories. Michelle, does anybody online want to say hi? They just want to hear chatting amongst themselves. You guys have your own chats in here, and everybody online has their own little chats going too. Some of you who have signed in online when you couldn't make it before know exactly what's going on there. So thank you to everybody. Before I ask Dr. Neal to introduce himself, I should introduce myself, which I should have done at the beginning of the evening. But for those of you who don't know, I am Danielle Hicks, and I oversee patient support services for GoTo Foundation. Prior to that, I was Bonnie's daughter, and only her daughter. No, I'm teasing. Lung cancer entered my life in 2003 when she was diagnosed, and we joke all the time that it's not even about her anymore. It's come so much further, and never in my life would I have ever imagined that I would be doing something like this all these years after her diagnosis. But I wake up every day, and I love going to work, and I love watching all of the exciting things that are happening, and I'm grateful that Dr. Neal's here to talk to us about some of those things tonight. Bonnie needs no introduction. Everybody knows who she is. She walks into a room, people are like, she's like famous. I'm like, really? No, I'm teasing. She is kind of famous. So I'm going to ask Dr. Neal before we break in tonight to just, not like he needs an introduction. Everybody in the room pretty much introduced him probably way better than anyone else can. But tell us who you are, why lung cancer matters to you, and then we'll jump into tonight's.
And why you do what you do.
Yeah. Well, first of all, I'm grateful to be here and also astounded at the stories that were shared. I think my shoes grew about 10 sizes, and now I have to fill back into them by the end of the evening. So,
no pressure.
You know, there are other great lung cancer doctors out there. The other patients just didn't mention their doctors' names or the institutions. Like, there's a lot of places you can get incredible care around the Bay Area and in Northern California and everywhere in the world. So I'm a thoracic medical oncologist, you know, on paper. I've been at Stanford back now 9 years at this point. I say back because I've shared this fact with a few of my patients. I was actually born at Stanford way back when. So I'm a native Bay Area product.
Wow.
Went far away to college down to San Diego in the UC system to get away from my parents. And then out for MD PhD at Northwestern in Chicago, and then out to the Harvard system, you know, where everybody has to be from Boston at least once in their life, right? And now I consider Boston a great place to be from, being a Californian, you know, with all due respect to everybody else who's done the lung cancer living room here. And I really enjoy what I do with the mix of patient care, a couple of clinics a week, running clinical trials, working with our incredible basic scientists on campus at Stanford, in Northern California, and everywhere in the world. But why do I do this? Well, I guess I'll share a story that I don't think I've shared with my patients, and probably haven't shared, you know, with many. But when I was 10, around age 10, it's a very formative time, right? You know, you're coming out of childhood, you're starting to actually pay attention to the world. My grandfather was diagnosed with colon cancer, and he got one round of chemotherapy and moved straight to hospice shortly after that. And I remember spending a very short time, you know, in and out of a couple of clinic visits and spending time with him. And I felt like it was just really, really fast and really unexpected for all of us. And I don't know if I even mentioned this story when I was writing my admissions essays to college or medical school or grad school or internship or fellowship or all of those things that I had to go through to train. But I always kind of wanted to do oncology and wanted to do cancer, but also cancer research. And my hardest decision was, which side do I do? Do I do the research side and go into a lab and really work on those basic problems, or do I treat patients? And it's amazing that I get the privilege of actually doing both of those things, as well as connecting with people incredibly deeply. And the stories that I hear and the bonding is unbelievable. I could never have envisioned how rewarding it is, at least for me. And sitting here hearing all the stories, you know, if I'm ever feeling down, I'm going to let you know, and you can invite me back to do another one of these things.
Yeah, for PTSD.
But I really do feel like, you know, this is a living room, and when I think about my own family's living room, it's a place that family comes together. And for me, this is not only feeling surrounded by family, but almost a family reunion here. So thank you.
And being a researcher and running a clinic is the perfect storm, and the perfect good storm. Because if you're just a researcher and you've never met a patient, you know, you're focused, but the end result is different than when you're in a clinic and actually doing research too.
Yeah, I always felt like the research was nice, but if we can tell a patient, hey, we're designing this right now and we want to bring this in for you, it's even better.
Right, exactly.
And I will say kind things about Boston too. It's where I got steered
Haussey's online.
into. Oh yeah, Haussey's everywhere all the time. He's certainly omniscient. But you know, that's the people that I worked with at Mass General Hospital in Dana-Farber, like, discovered EGFR mutations while I was there. Discovered ALK and figured out how to test for it. I heard the story when I was a fellow of this 20-year-old guy who was on a clinical trial of this drug called PF0012341066. And I'm like, okay, well, you know, it might be hard to remember that license plate name, but it was working. And this tumor was melting away on a phase 1 clinical trial, which is usually our expectation is, well, we'll see what the side effects are, and then we can see whether it's effective once we get up to the higher doses. But that drug became crizotinib. And so all of these key stories, and I said, well, if there's 2 huge stories in lung cancer, how many more are there? I couldn't in my wildest dreams have envisioned immunotherapy being successful, and we'll talk about that and touch on that tonight. And the combinations and the number of things in our tool set and the number of new molecular alterations that we're figuring out, effective therapies that are well tolerated too, it's an unbelievable time to be privileged to be in this field.
I have a question for you, and I know it's not one that Danielle was thinking of asking, but
She never does that. So.
You just prompted me to think. And we've told you this in this meeting several times this year, that more drugs have been approved for lung cancer in the last 3 years than the last 5 decades. What caused that to happen? Why is it? Why now?
Well, that's I'm not sure there's a simple answer to that question, but certainly the combination of, so the targeted therapies, if we think way back when, the EGFR, discovery of EGFR mutation, and the fact that some of the original pills, gefetinib or erlotinib, or now known as Tarceva, the fact that they worked was a total accident because the companies were actually going after wild-type EGFR and trying to cause rashes and trying to cause diarrhea and trying to inhibit wild-type EGFR. And it was a complete surprise that some percentage of patients, 15% in the US and even up to 50% in Asia diagnosed with lung cancer, usually people without a smoking history, but not necessarily. Complete surprise that their tumors had mutations that were like a switch stuck on, and these drugs bound in there even better than to the wild type, and the tumors melted away. Like, that was an accident, right? It was an incredibly fortunate accident of targeted therapy, but it wasn't rational drug development.
Wasn't a surprise.
Yeah, and an amazing surprise. And then, so the rational aspects, I think, we're now seeing the fruits of. In 2005, T790M was discovered. In 2013, a T790M inhibitor that was well tolerated and very effective, finally out there. And then the crizotinib was an accident too. Phase 1 clinical trial. Hey, ALK is kind of uncommon in lung cancer, but maybe we'll design a test for it. Again, a pleasant surprise, but a little bit backwards from where you expect the research to be.
Right.
And I think we're finally at the point where there's a critical mass of research where we understand enough about the biology that we can design the right drug and understand why it works instead of going from the action back to the mechanism we're moving forward.
There you go.
So we've got this momentum going now.
Yeah, okay.
Very exciting.
Good answer.
I want to jump into all of the juicy treatment stuff and the research and what's going on. But first, I want to talk about the low-hanging fruit. And we've been trying to do this a lot at the beginning of these meetings, in particular, recognizing that it doesn't necessarily pertain to all, or doesn't at all actually pertain to most of you in the room, and that's screening, and where we are with screening. When we look at the amount of people in this country alone that currently qualify that are not taking advantage of screening, it's roughly 10 million people, right? So we talked earlier about the 225,000 people a year diagnosed. There are way more people than that walking around that qualify for screening. And I'm going to tell an interesting story. And I think you know Andre and I did this. So we talked a little bit about T790M, and my sister and I don't qualify by today's current guidelines for screening. But given that our mom was a 3rd generation on her mother's side, lung cancer survivor, the only one that actually survived it, there's some anxiety, right, about it. So we self-paid and went up and got a low-dose CT scan. And I will tell you, what I thought of as barriers, with people who either current smokers who didn't want to be told not to quit and didn't want to have to do this, all these things that kind of people have been talking about. One of the interesting things was how much anxiety my sister and I had leading up to this scan. Like, there was no reason we should have had all of this angst about it, and we did. I mean, we're to the point where she's like, I've left my house. Have you left your house? Okay, I'm in the parking lot. I'm not going in without you, blah, blah, blah. And we're having this conversation back and forth, And it's like, okay, you go first. And it's like, okay, I'll wait here for you. And it was really interesting, right? And I got a phone call later that night from somebody within this pulmonologist's office asking me a couple of backup questions, and I was like, oh, here we go, right? And I was panicking. And of course I wound up texting the doctor, and she texted me back at like 11:30 that night. She's like, your scan is fine.
Was it Melissa?
It was Melissa.
Yeah.
I was like, she's like, your scan is fine. She's like, it was just stuff we needed to do to enter you into screening, blah, blah, blah.
Okay.
So, and then Andrea, my sister, didn't hear about it for another 2 days, but it was really this thing, and I found it interesting that I get a mammogram every year. I don't have that kind of anxiety about mammograms, right? So it was just kind of food for thought. But I think one of the things I want Dr. Neal to talk about tonight is what's going on in this screening space. I know Oncocyte talked a little bit about it. We have a couple people that have been involved in different trials and studies looking at alternative screening options. But it is so important, and you guys are the perfect people to spread the word about screening for lung cancer, to get the word out there to your friends and your loved ones about what's available today and why they should take advantage of it and do it. You've heard from patients in the room who were diagnosed early and what those outcomes have looked like. So you want to talk a little bit about lung cancer?
Can I just throw something in
yes.
just to end what you said, because you're so absolutely correct. Lung cancer is almost 30% of all cancer. So if you look at that 30% that represents all cancer, if we knock it down 30%, look what happens to all cancer. It's reduced in a huge number, and that means lower cost of healthcare. It means so many good things. And Dr. Neal's going to talk about this. We've got KRAS and small cell and a few other things that we have to work on, and we've got all these other mutations that we're working on. But we are headed in the right direction, and if you throw screening in that, which is a huge percent of lung cancer, if caught early, we can address it and get to a chronically managed disease. That's huge. That's absolutely huge. What's happening right now in research is huge.
Well, yeah. So no doubt screening is absolutely important, and Danielle, I'm sure you've heard and discussed the word scanxiety in this forum once or twice before, and we know even our patients, our survivors who have had 27 scans in the past, there's something about going and getting the scan and then having that result somewhere available and then coming back and discussing it. It's very anxiety provoking, and I have to say it's probably like back in the days I'd take the SAT or something. I'm like, what's my score, right? But it's in a very personal, very, very life-threatening way, potentially. So that's absolutely real. The screening scans, the interesting thing about them is the only populations that have been screened are people who have a smoking history. Active smokers, people with a history of smoking, ages actually a limit of age 55 up to 80 is where the current guidelines are here. And hearing around the room, I would suspect if we took a poll, many of the people here didn't have a smoking history. Many of the people here. To eliminate smoking-associated lung cancer seems like an easier problem overall. And if we talk about screening, I think that's an interim solution to reducing the exposure in the first place. Ideally, over the long term, if we could say, hey, everybody quits today, then suddenly 30 years from now, lung cancer is 10 to 20% of the incidence of what it is with those naturally occurring, not great, but sporadic, random, truly have no explanation lung cancers that aren't associated with smoking. But since we have smoking as part of our population, and people smoke, and I always like to point out, like, if you go to tobacco.stanford.edu, it's a fantastic website. It's a website that shows all of the marketing information spread by tobacco companies all the way back to the 1910s that show how the companies made us smoke as a population, right? That and if you show people this was done because somebody kind of forced you to do it, then they have a realization like, oh, it's not my choice, and people like to have choices, and they don't do it anymore. So tobacco.stanford.edu is a great place to go spend a little bit of time. Things like, 40,000 doctors at the American Medical Association meeting in the 1930s chose this brand of cigarettes over this brand, right? And like those sorts, and they would hand out free packs of cigarettes at all the American Medical Association meetings. Like it's so I think first and most importantly, like working on the exposures that we have control over. Screen everybody who's eligible, absolutely. Then we can find early stage lung cancers and get to where kind of my vision is for 10 to 20 years from now, which is we're going to be running the kinds of clinical trials that the breast cancer groups have been running for decades, where we need 10,000 patients to participate so that we can find these little tiny differences in cure rates, right?
Yeah.
But screening for lung cancer or any cancer shouldn't be an accident.
It shouldn't be.
Everybody who's finding lung cancer by accident. We should be proactive about finding it early, and everybody should get a screen if they want one, because anybody can get a mammogram and anybody can get a colonoscopy. The only thing that cuts people out is the age group. To be able to do that. But we have to work on that, and we're hoping that the FDA is going to approve this. It's already happening in Europe, where they're starting to put on cigarette packages what they put on years ago. Cigarette smoking can cause lung cancer. Now they're going to be putting cigarette smoking can cause heart disease, cigarette smoking can cause strokes, cigarette smoking can cause eye cancer, and smoking is a much bigger issue than just coupling it with lung cancer.
Yeah, and I honestly
good.
don't think we're gonna get rid of smoking, not in this world, not in my lifetime, right? So in spite of that, and with that being the probable truth, now what? Now what are we gonna do? How are we gonna help these people? Not to mention, never smoking lung cancer is still number 5, right? Out of all the cancers, it's number 5.
Exactly.
So lung cancer is still a big problem.
Right.
Sorry, Dawn, I need to get on my horse.
Yeah,
I'll get off.
Right.
Yeah, but I absolutely encourage anybody who's currently smoking or has a smoking history at their next physical, talk to their doctor and say, hey, do I qualify for a lung cancer screening exam?
Right.
I'm not sure I recommend never smokers getting low-dose CTs at this point in general.
No, nobody does. It's not recommended anywhere in any.
Because we do worry a little bit about what's the exposure of that little bit of radiation over the course of 40 years.
I have a question about that, and I don't know if this is legit. Well, I hope it's a legitimate question. I don't know, but anyway, low dose CT. I have been told that is you get the same amount of radiation as like I will get when I fly to Toronto and back tomorrow. Is that true? And if it is, then why isn't my doctor talking to me about, well, before you get on a plane, and why aren't there signs, before I walk down that ramp letting me know, but God forbid, should I be worried
about that radiation?
Lung cancer, you're not going to give it to me. I mean, it's those
Or a day in Denver.
Yeah, I mean, it makes, it seems a little
backwards.
Seems kind of like bullshit, actually.
Yeah, right.
Just throwing that out there.
Sorry. I mean, we don't actually know. There's never been a proven connection between flying on planes and cancer.
Yeah.
Or between getting a CT scan and developing cancer.
Right.
The data that we have to say that, well, ionizing radiation probably causes cancer in the future is from kids who got treated for mainly Hodgkin's lymphoma, right? When they were little kids, got a lot of radiation to their chest, and then also from natural disaster types of things, like Chernobyl types of things. And they kind of extrapolate down and they say, well, if this many cancers was caused by Chernobyl and this many is caused by radiation to the chest, and this many would be caused by, but we don't know that it's linear, right? And we can't point to anything for any patient diagnosed with lung cancer or any sort of cancer and say, that's what caused it. We can't say, that's the cigarette, or that's the plane flight, or that's, it's a combination of many things that we don't fully understand altogether. So the problem with CT scans for people who don't qualify for the screening is, one, maybe there's some risk of the radiation, but two, if there's a little nodule there, there's lower probability that it could be cancer, not zero probability, but lower probability, and people will go through maybe a lot of testing. A few people might get biopsies. A few people might have side effects from those biopsies. We don't want to hurt people from these tests either. You know, like a lot of mammograms are done, and to biopsy the breast tissue is a little less invasive than sticking a needle into the lung.
Yeah.
So we worry about the risk and the mental struggle associated with, oh, what if this is a cancer, right? Even after having a positive scan, many of which are not positive. So only a small fraction of nodules actually turn out to be lung cancer.
And as biopsy techniques become more, as they evolve in technology, like navigational bronchoscopy and those types of things come into play, those risks lower a little bit. Those sort of conversations are happening with patients. Go ahead,
And that's
Sally.
where we need blood tests. Sally, I was hoping you would talk, having been a participant on one of the original trials.
Because I went through the low dose, but my mother had it, her brother had it, my paternal grandfather had it. My mother's was found accidentally on an X-ray, and we were told at the time, and this was in the mid-70s, that usually when it was found on an X-ray, it was too late because it wasn't small. Well, luckily, she had it 3 times, and she lived 22 years without any treatments or anything, but it was all different. But the good thing today, at least this was what was pointed out to me when I was in the ILCAP, was that the low dose can find things before an X-ray ever could, and it would not be the amount of radiation that you would have with the chest X-rays. And we also were warned that there are a lot of false positives. I mean, they gave us all of that information. So even if we are getting radiation from these today, it's not the same amount as if we had X-rays that you had to have every
You're saying if you had to have successive X-rays as a screening tool.
So that's my 2 cents.
And the radiation from all sorts of radiology scans has dropped dramatically over the last 2 decades because the detectors are so much more sensitive. It's computer technology, so we can use a fraction of the amount of radiation now in CT scans and X-rays.
Ron, then we'll come back to you, Don. And then I want to get into treatments. Go ahead.
Yeah, I want to talk about early detection because it shouldn't be discovered by accident, and yet so often it is. And so I'd like to hear your thoughts about 2 things. One is a breathalyzer sort of analysis of the RNA that comes out of your breath as a means of early detection, and where you think that might be, because it seems like if we can detect alcohol levels, we should be able to detect RNA levels and to detect whether or not you have cancer in your breath. The second one is that at World Lung, they announced something about Scotland doing some detection early ahead and finding evidence of cancer years before it was showing up on a CT or an X-ray.
My question's almost similar. A couple years ago, I sat on panels for the DoD for the Lung Cancer Research Program, and there was a lot of applications coming through for liquid breath and saliva, and that was sort of the same question: is where is that technology today? Are they any closer? I know like Garden and Foundation and some of them are pushing towards, being able to detect cancer in blood.
Yeah, no, I think these are great questions, and I think looking forward, it's clear that even if we choose to do low-dose CTs for a broad population, that we'll want to do something less invasively to confirm whether that is a high risk of lung cancer or a low risk before we start doing CT-guided biopsies, very invasive tests. So I think it is exciting, and one of the plenaries at the World Lung did show if you combine a screening program with a blood test, so it was kind of a microsomal RNA blood test, it's nothing that's commercially available or even close to that, that it could up or decrease the probability that a tumor was lung cancer by as much as 30-fold. So you could rule in or rule out by combining a blood test with a cancer. The simple circulating tumor DNA story, is a little more complicated because most of those tests require you to know what mutations are in the tumor to find it back in the blood. If you don't know what you're looking for, it's a scary realization that I had when we were early doing collaborations with Max Dean in one of our labs at Stanford that has a very sensitive test. that many normal volunteers have kind of mutations that are associated with cancers floating around in the blood.
Right.
And we don't know what those mean. Turns out we didn't know what they meant. We thought maybe it was the sunburn from when we were a kid. But they're mostly from normal white cells that are, as they're dividing, they accumulate mistakes, and those mistakes don't really affect you in any way whatsoever. So it's not enough to just find a KRAS mutation or a P53 mutation in the blood. You have to have other information in addition.
They said there was recently an experiment where dogs were able to detect in the breath that you might have lung cancer or a certain type. And there was a couple of MIT studies that were also looking at RNA in the breath as a means of advancing a breathalyzer. I mean, it seems to me that, but then I realized there's 1,500 different trials on breathalyzers, so it's like there's a lot of throwing spaghetti on the wall.
And then one of the downsides of finding it in the blood early is then how do you treat it? You know, you may be able to pull up an EGFR mutation or something like that, but how do you treat it if you can't see it? You certainly can't radiate it. You can't do some of the things that Don's been talking about today about chronically managing the cancer. So it's a
Stage 1 and 2, they won't even test for mutation.
Right,
Yeah.
right.
Because it's curable.
Right.
And Don, I didn't really answer your question, and I have to say, as more of a medical oncologist, I'm not as familiar with the early detection and the research. But back when I started at Stanford, I was collaborating with pulmonologists, and we were doing exactly this. We were collecting exhaled breath condensate in a bag and putting that somewhere, and then saying we're going to save that and try to do molecular testing on it and look. And I think the problem is that all lung cancers are so different that there's no one common, like, this is lung cancer and this isn't, at least that we've found so far. That there can be RNA signatures, there may be DNA signatures, but those are kind of late events. Maybe we'll find cells or remnants of cells occasionally. But I haven't heard of anything where this is the test for lung cancer. And with computers and enough technology and enough samples from patients who are participating in these sorts of correlative research studies, people who have cancer, you need them as this is the case, and then you have control patients too who are volunteering. I think we can come together hopefully and find things that will augment these low-dose CT scans. And also, I'd point out on the NLST, on the National Lung Screening Trial, and in many of these trials, they did collect other biological specimens. So we're working on processing the blood and saying, is there circulating tumor DNA from that, and can we find any other signatures? With today's technology, instead of outlining those plans a decade ago when we started the trials. So oftentimes we want to start the trials, but collect specimens so that we can test them in the future once technology gets better, which it always is.
That's great. I want to just pause. Michelle, do you have anything online? Anybody want to say anything? Okay, I just want to make sure. I want to
The
jump
whole world
into-
is quiet. except
Yeah,
for-
right. I'm sure.
They want to hear about what's working.
Yeah, I want to talk. I want to jump a little bit into PD1, PD-L1, tumor mutation burden. What's relevant? When is IO right for a patient? What's going on right now with immunotherapy?
All right, so just
jump
lung
in.
cancer 101. Let's
Right,
do it. Well,
let's do it.
yeah, maybe we'll start off on this idea first, kind of go through by stage, right? And so if we're fortunate to detect lung nodules when they're early stage 1, which is basically in the lung, stage 2, which is generally a little bigger tumor or moved to a lymph node in the center of the chest, but still in the lung, not between the two lungs. Or stage 3, which is lymph nodes in between the two lungs or fairly large tumors, then our primary goal is to cure those cancers, right? Our primary hope is always to cure every single lung cancer that we find, but we're not sure how to define it in terms of stage 4 patients who are living long time with treatment. So stage 1, we think surgery or maybe radiation. Often we don't do molecular testing on those tumors because the chance is high of getting rid of those. For stage 2, again, surgically resection, often with chemotherapy afterward. Still the most solid data to cure an additional population of patients after surgery for stage 2 and some stage 3 lung cancers is 3 months of chemotherapy after surgery. Sometimes chemotherapy before surgery, but chemotherapy is where all of the data are. And with all of the hype about targeted therapies and individualized therapy and immunotherapy and everything else, the data are for cisplatin is preferred, 4 cycles, 3 months. It's not fun, but as Tina said, it's an insurance policy is how I describe it to patients in the adjuvant setting. So chemotherapy is still the mainstay of early stage treatment. For stage 3, we often incorporate radiation, and sometimes for stage 1 and 2. Still, again, no clear role for the targeted therapies in that. But for stage 3 with chemo plus radiation, there has emerged a role for immune therapy. Regardless of PD-L1, regardless of testing, it's fine to do the testing. And if we know molecular status, that affects our probability of it working a little bit, but we still often offer it to everybody. And a year's worth of immune therapy with a drug called durvalumab after chemotherapy plus radiation improves cure rates in stage 3. So that's kind of the early stage non-small cell lung cancer overall approaches. But then with stage 4, when a patient's diagnosed and unfortunately it's already spread outside of those boundaries of radiation where we could try to get it all in one radiatable field or with surgery, then we say, how do we maximize, first and most foremost, quality of life? You gotta live well. With or without cancer, our primary focus should be on our quality of life, right? Not saying like my 5-year-old does, which is I want a lollipop every 5 minutes. Like that's not maximizing quality of life, right? But
Well,
like,
it is his.
it's maximizing his. Made mine worse that I ever showed him what a lollipop was ever, right?
Because he's up for 48 hours.
But like, focus on quality of life, both decisions now for the long term to make your quality of life better in the long term, but also like, how do I have fun right now too? And balance those two things. That's what life is about with or without cancer. And if we're living better, we're gonna live longer too. That's just part of it. So how do we live better? Well, we give the most effective therapy first, and one hopefully with the fewest side effects in balance to that first. So that's the concept of personalized therapy and why testing is so important for non-small cell lung cancer. And the testing that we recommend for every patient, newly diagnosed, adeno or squamous, first they have to figure out what flavor it is. So I describe those as the flavors. Adeno is more gland-like, squamous is more skin-like, and those are the major subcategories. Sometimes there are neuroendocrine ones too that go in a little into the small cell direction. But for adenocarcinoma, PD-L1 testing, that takes a day or two generally. That's almost part of the diagnosis. EGFR mutation testing, absolutely critical. That can take a week or two and is worth waiting for. ALK testing, ROS1 testing, and generally BRAF testing. Those are less and less likely that I listed in order. So EGFR mutations in the US, 15% of patients. And for people who haven't smoked, up to 50% chance. ALK, 4 to 8% depending on the population. ROS1 and BRAF about 1%, very, very much lower. But those are the 4 targets that we have that are these switches that turn on and off, that we have drugs that work better than chemotherapy in the frontline setting, better than immunotherapy in the frontline setting, and are generally better tolerated also. So we want to give those first and say, let's wait on chemotherapy and immune therapy till later. So it's important to get all the molecular testing, at least with kind of that core set. And other testing can be done for later. Then if those are negative, then we say, well, what's the best treatment overall, at least for adenocarcinoma? We say, well, chemotherapy was good. There are trials that said adding immunotherapy is better. And chemo plus immunotherapy is the standard of care. But for patients whose tumors have high PD-L1, so that's, I described PD-L1 because I know many of the patients know the lingo. I'm super impressed by everybody, by the way. Know the lingo, but sometimes I say, well, okay, how do I explain this to simplify it? PD-L1, I think of it like a shield on the outside of the tumor. So basically, the tumor from whenever we couldn't detect it and it was very small may have been growing over time. And the immune system may have put pressure on that tumor and tried to fight it. PD-L1 was the shield defense against the immune system that some tumors evolved to basically say, go away, immune system, you have to shut down. The immune system plays by the rules. It's part of our normal systems. So the tumor can grow shielded from the immune system at that point. PD-L1, when it's really high, suggests that there's more shield. And then if we give an antibody to PD-L1 or the detector for that, which is PD-1 on the other side, that breaks down that shield, and then the immune system can come in and do the job that it was trying to do. This is not creating an immune response. This isn't coming up with something out of nowhere. It's relieving that block that the immune system was blocked from doing. So it doesn't work for every single patient, but we do know for patients whose tumors have high PD-L1, it's a lot more likely to work, even more likely than chemotherapy by itself. So sometimes we give immune therapy by itself, save chemo for later. Squamous, very similarly, chemo and sometimes immunotherapy, and with immunotherapy or immunotherapy by itself. But if patients have history of autoimmune problems or other things, or high risk from chemo or high risk from immune therapy, of course we want to make it tolerable together. And surprisingly, it is for most people relatively well tolerated to try that combination of chemo and immune therapy. So that's the US standard of care right now. So I know other countries are other ways.
Yeah. Some people are talking about chemotherapy and saying it's not your grandfather's chemo, because we have so many great drugs now that'll keep you from being nauseous and getting sick and all of those things, that forget all of those things you learned or watched on movies, where people were on chemotherapy and immediately started going downhill. That's really not the case.
That really was my grandfather.
Yeah, exactly.
I really saw that.
Exactly.
He felt rotten the entire time, said, I never want this anymore.
That's what's in everyone's thought process, and it doesn't have to be that way.
So I assume when patients come and they're hearing about chemotherapy that they're going to hear what they had from TV or whatever their friends of a friend had experiences with chemo, which usually wasn't the first chemo that person ever got that they're hearing about.
Yeah.
So I assume, hair loss, not as often as you might think, nausea, vomiting, usually more constipation now because of all the drugs that we're giving to prevent the nausea, vomiting, and slow everything down.
Right, exactly.
And, low blood counts, not as much, like hospitalizations, not usually. Like quality of life's pretty good, and we have patients that work for the most part, in between cycles of chemotherapy.
And gaining weight instead of losing weight.
Exactly.
Right,
as we've stopped the tumor from growing, oftentimes people say, I feel better now.
Right, exactly. Yeah, so.
Just a question for Dr. Neal. Chemo gets a bad rap, but it seems like now with like the Keynote 189 combination trial, mixing immunotherapy and chemotherapy actually improves overall survival by over 50%, because the chemo agitates, is the way I understand it, the chemo agitates the tumor so that the immunotherapy can see it easier. And I had one other question. I'm getting CyberKnife next week, and I've heard about this abscopal effect, where actually CyberKnife, I've had like 5 different immunotherapies, can actually irritate the cancer tumor also and reactivate previous immunotherapies.
So so the Keynote 189 trial that Dawn talked about is the trial with chemo adding immune therapy, and showed an overall survival benefit that was better than patients who got chemotherapy then standard of care. Many patients got immune therapy afterward, but not 100%. So the question is always, when those data first started to come out, I asked myself, is A followed by B really worse than A plus B? And I still don't think we know whether there's some sort of synergistic effect, or what we're seeing is an additive effect between those. There's no hard biological proof. It becomes very, very hard to tell what's working when we give chemo and immune therapy together, and to say which is it. Is it the immune therapy? Is it the chemotherapy? Which one's happening? So oftentimes, I don't feel bad if a patient isn't fit for one or the other, to say, let's just start with half of it and we can always add the other part in later. But for a population that was studied, yes, A plus B is better than A followed by maybe B in terms of overall survival.
And patient-reported outcomes are really a huge part of research. You think of research only happening in the lab, right, at the bench, but it's happening in real time.
Are you plugging our registry right now?
Oh, yeah. Probably. Is David upstairs? Did he hear that?
I have a question.
And we're starting to see data from not only patient-reported outcomes collected through trials, but kind of real-world patient experiences,
Exactly.
collected, and those data, as we merge those together, will be much bigger than anything in a small clinical trial.
Exactly.
Overall.
Exactly. Yeah.
So I just want to make sure I understand, because I hear what you're saying, and I know that they're studying a lot of things right now, IO with radiation, IO with chemo, but there's studies out there too, and I'm guessing it's the same thing when we're talking about targeted therapies and chemotherapy, right? Combining chemotherapy with targeted therapy, or what order this happens in. Like sometimes you hear about patients, they got chemotherapy first, then they got their targeted therapy, right? And they've been on their targeted therapy for blah, 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 blah. Does it matter what order? And if it does, why? What are they looking at? What do they know?
Matters.
Yeah, so I haven't seen very, very strong data suggest that order matters.
Okay.
I think every tumor is going to be responsive to a certain set of things, and unfortunately, many tumors are resistant to some things too. And trying what we predict to be the best thing first is the best approach, right? But then we can move on, and we have so many different tools and so many different options, and chemotherapies that I could list for 5 minutes if we had to, that we keep needing to try if the tumor is resistant. But I don't think I've seen data to say that if you get chemo and then a targeted therapy, the targeted therapy is worse, or vice versa.
But in say the community.
Yeah.
Where the patient wasn't tested for genomics, and all of a sudden they just start on chemotherapy without knowing that there might be a target, I think that's when it could be a problem.
Right. So we don't favor tested. If newly diagnosed non-small cell lung cancer adenocarcinoma with PD-L1 of 90%, the community oncologist says, let's give chemoimmunotherapy, and the patient says, I want to get started with treatment yesterday. And everybody starts on chemo plus immunotherapy, and then, there's an EGFR mutation found 2 weeks later, or worse, never tested for in the first place, right? And so the patient doesn't know, here's this giant opportunity of being on a fairly easy pill therapy that could last for longer than those other treatments. So I think the sequence may not be as important, but the missed opportunity of not doing the testing shouldn't be underemphasized.
Right.
I think, Catalina, I'm going to get to you. Michelle's got the one from online. Go ahead.
So once immunotherapy stops working, does the cancer seem to come back more aggressively?
Okay, I'll repeat the question. So the question is, if immunotherapy stops working, does the cancer come back more aggressively? Aggressive is a relative term, and when patients ask me if my cancer is aggressive, I say I don't really know what that means. I mean, lung cancer is often persistent, if not aggressive. I don't know what an aggressive cancer is, but some tumors, just because of the biology, respond to immune therapy, and some don't. And those tumors that don't respond to immune therapy, effectively, if we're breaking down a shield that didn't exist and there was no immune system to fight it, we're not giving treatment. So I think it can be perceived that lack of treatment seems to be like, it's growing more quickly on immune therapy. In fact, some people have even said there's a phenomenon in 5% of patients called hyperprogression. So hyperprogression, i.e. the cancer for some reason may be growing faster, still a controversial subject. But maybe one of those reasons that giving chemo at the same time may mask any of that effect if immune therapy is doing nothing. Now, after immune therapy doesn't work, if somebody's tumor responded well to immune therapy and then starts growing again, we don't really understand what's going on, and it's a variety of different mechanisms, really an active area of research to say what's going on. Is the immune system ignoring it? Did the cancer change its behavior? Did we select a small set of cells? We don't really know what the biology of that resistance is. And Don, I'll have to get back to your abscopal question in a few. Can I answer the abscopal question? Or do you want to move on?
Hyperprogression?
Yeah.
And is that true with EGFR mutation with the MDM2 or 4 mutation? Because I had a friend that got immunotherapy before she found out she was EGFR, and then she hyper-progressed, and she had the MDM4, I think, mutation.
So, I like to think of it as, we're not giving effective therapy, and often immune therapy is less effective in EGFR mutant lung cancer, often a little less effective in ALK or ROS1. Some of these targetable lung cancers, immune therapy is less effective. So if somebody got only immune therapy, their cancer would be progressing, and that might be perceived as hyper-progression in a sense. And I'll just quickly talk about the abscopal effect. So the abscopal effect is if you radiate a cancer in one spot and irritate the immune system and really engage it and say, hey, fight the cancer now here because of radiation, maybe the immune system will go and fight cancer in other places in the body. This has been documented with some of the earlier immune therapies in melanoma especially, and in some renal cell cancers. Has been a little less clear that there have been documented effects of that in non-small cell lung cancer, although I am a believer in overall tumor burden probably matters, and it's reasonable to consider radiation. There is some data to say radiating many spots of tumor lowers the overall burden and may improve overall survival, although we're not doing that routinely, often because we have good systemic drugs at this point. So I've asked many doctors. I actually went to World Lung and asked a few doctors, as every talk mentions abscopal. I say, have you ever seen it? And they often say, well, I thought I did, but it turns out that it was just progression at the end.
Can you explain to everybody exactly what tumor burden is? High versus low?
Oh, yeah. So when I said tumor burden, I'm thinking, how many different sites of metastases and, what the overall amount of cancer cells in somebody's body is, different than tumor mutational burden. So TMB, or tumor mutational burden, is a test that's done, usually DNA sequencing of the tumor. Sometimes it's being done by blood, and it's predicting how many mutations are there, besides the EGFR and the ALK and the other things that we're looking for normally, how many mutations are there in a cancer? Because even an EGFR cancer has tens of thousands of abnormal mutations. Smoking-associated lung cancers have hundreds of thousands of abnormal mutations. And it seems to be that one of the predictors of what made the immune system want to fight the cancer in the first place, way back when we didn't even know that there was a cancer, is these tumor mutations make all kinds of proteins on the outside of the cell that are irritating. That makes the tumor cell appear abnormal, like a virus or a bacteria in our body, and that's one of the drivers that the immune system goes to fight. So the tumor mutational burden is one of those prognostic kind of predictive markers of whether immune therapy might be working. In reality, I haven't found it useful yet because it takes a few weeks to get that information back. And often once EGFR, ALK, ROS1 are negative, we're starting immune therapy anyway. So we're not looking for an excuse not to give immune therapy, although we have talked about there are side effects to immune therapy, so maybe we could not expose some patient population to immune therapy.
Right.
If it's never going to work.
Right.
Because TMB is low and PD-L1 is low, and all these other predictors say immune therapy is, 1 in 1,000 chance of working. It's probably not worth getting the 5 to 10% risk of side effects from it.
And that goes back to your quality of life.
Exactly. Right?
Yeah.
One of the areas of research is really finding patients that will never respond to immunotherapy and not giving it.
Yeah.
Because every patient at some point will probably get immune therapy.
Right. Right.
Carolina.
Well, before I was going to ask my question, I failed to mention in my haste to be super brief with our summary is that my mom is also a Dr. Neal patient, which I wanted to mention. And now my two questions were both asked by Dawn and Bonnie. Bonnie was about the TMB, and Dawn, I didn't know that term abscopal, so I had heard the concept of radiating and then attracting the immune system, but it's all good now. So questions answered, and I think someone here.
Was it Joanne, Evangeline? Somebody over in that corner, I think. Oh, Joanne.
I think maybe you already touched on this, but up until now at least, I've thought that immune therapy has not been effective against EGFR mutations, that we've actually been excluded from trials because we lower the statistic. Is that still true?
I don't think the exclusion was meant to be exclusion or discriminatory. I think it was mainly because most of those trials were looking at kind of the first or the second line setting, and EGFR patients had better alternative treatments of pill therapy, so that's what they should be getting instead of first line immunotherapy. So there are some data for sure, both single agent immune therapy as well as combination chemotherapy plus immune therapy in EGFR mutant patients. Right now, putting it all together, kind of simplifying and distilling, at Stanford, we actually took some of our patients who had molecular alterations, put them into a registry run by the French, Julien Matsiris, and it's called Immunotherapy. It's published now in the Annals of Oncology, and we lumped together about 400 patients with EGFR, KRAS, ALK, and ROS, and MET, and some other ones, and we found EGFR, PD-L1 probably does predict somewhat. But I think of it as kind of one notch less likely to respond to immune therapy than non-molecular targeted alterations. ALK and ROS1 almost never responds to immune therapy that we've seen. And then some of the other alterations vary. KRAS, of course, responds, just like any other kind of lung cancer for the most part to immune therapy. So I don't think of immune therapy in EGFR as a never, although I think about that for ALK and ROS, maybe never. Yeah, and for EGFR, I factor in the PD-L1, but there's many other treatments that I would think about before immune therapy.
And doesn't it all really come down to having an educated decision where you get as much information as you possibly can get from the patient's tumor to make an informed decision versus, chemo, IO first.
Exactly. So I think knowing about EGFR mutations first line makes total sense to avoid immunotherapy during that entire time.
Right.
Second line, there's more controversy. Do we do chemotherapy, maybe with anti-angiogenics, which are kind of coming back into vogue, especially anti-angiogenics, bevacizumab, ramucirumab, some of the pill therapies, in combination with immune therapy may have some synergy. So we have clinical trials now testing those angles. And what is the best order, and also what's most tolerable, because adding it all together, the kitchen soup approach, there might have been a lot of benefit of doing those things sequentially, but quality of life is worse with everything together. Yeah.
Barb?
Yeah, I just wanted to sort of bring that up because I didn't say it earlier, but Dr. Neal's also Dave's second opinion guy. So, we're in the fan club too. And for Dave, who went through the targeted therapy first and then chemo, and that failed, started basically progressing on even while on the chemo, and now he's giving the Keytruda a try, the immunotherapy, which Dr. Neal confirmed was the way to go. And it just seems like it is obviously hard to know, but what we really appreciated was the advice because we had heard from a lot of people, and including in this room from other doctors, that, look at the combinations, that maybe that chemo and the immunotherapy in combination have a better chance. And I think the way that you explained it is that, you could throw everything at it and something might work, but if the Keytruda alone is going to work, your quality of life is going to be so much better than if you've got all four of these things and then we don't really know which one is working. And if it doesn't work, then we can always try the other stuff later. So I just wanted to say that was a really, really important piece of advice from you, and we really appreciated that, because we were thinking, oh no, we want to throw the kitchen sink at it. But the whole quality of life was really important.
Yeah.
So, we are hoping it's going to work, but we know if it doesn't, there's always the kitchen sink approach later, right?
So I think just to put a couple of names to this instead of staying in the general. So the one clinical trial that had patients with EGFR mutations and ALK rearrangements, which used chemo plus immunotherapy, was the Empower 150 trial. Had carboplatin, paclitaxel or nab-paclitaxel, bevacizumab, and atezolizumab. And this 4-drug combination was tested in EGFR patients, seemed to be better than the same combination without the immunotherapy in that patient population. But it's a tough old regimen. It's paclitaxel is you get numbness and tingling and you lose your hair kind of drug of the old days.
A week.
Yeah. 1 to 3 weeks, right? And so I don't think we know right now what that sweet spot is between tolerability and effectiveness. And there are certainly patients for whom that 4-drug approach might be the right one, and you know, we need a response yesterday. And there are other patients that have a little more time to say, let's try these things sequentially.
So I have a, go ahead, Don. Oh,
so
go ahead, Rick.
I have a quick question. So when you're on targeted therapies and they stop working, it's either because of a mutation or the drug not getting where it needs to be, like the brain, as an example, with crizotinib. Then you go to another drug, and when that drug stops working, it could, again, be a penetration problem, or it could be further mutation. Then you go to another drug, it could be further mutation, or again, it could be a penetration problem. You don't really know. So you get 4, 5, 6 different drugs in. Theoretically, the cancer could be a lot more complex, as in different mutations, correct?
Right.
And if so, does that lessen the effectiveness of chemo, or does it would the chemo sort of work the same, as far as sequencing?
Right. So this gets to kind of the concept. Thanks, Rick. I didn't ask him to ask this question. I really didn't, because when we get tumor heterogeneity is not something I enjoy thinking about.
Right.
And,
Exactly.
You know, resistance, like say it's going to work and we'll figure it out when the time comes. So we'll have to talk later about asking that question. Anyway.
Well, you probably know why I asked it, since you are my oncologist.
But so even from day one, with all of these mutations, the tumor does have a spectrum of different bits and different parts, which are all slightly different than each other. And when we give a strong targeted therapy that affects most of the tumor cells, there's unfortunately always a few that are kind of hanging on that say, well, I've got whatever this mutation is, so I'll keep growing. And then that's the population that we see from then on. And when it's not getting enough into the brain or not as potent an inhibitor, it's easier to give more potent inhibitors. But even with the perfect drug, there's always a pre-existing population of cells, and that's the problem of acquired resistance. So for patients who have tumors that responded really well to a pill therapy and grow back, we definitely encourage repeat biopsies, because we want to figure out what's going on now. This tumor is different than the one that it was originally.
What's the driver?
Yes.
Who's driving the
Who's
bus?
the new driver?
Right.
What's driving the bus?
So the original driver was ALK,
Right.
but then you can basically, you have somebody who, changed ALK or EGFR, right?
Mm-hmm.
You have, some change of that, right? To say, oh, I don't care about your pill therapy anymore.
Right, exactly.
I've changed. That pill therapy doesn't affect me anymore.
Right.
That kryptonite, I'm resistant now. Or there can be a new driver. Basically, okay, ALK, you get a side, but I'm putting a new steering wheel and a new gas pedal in here, and I'm coming in as a new gene. Yeah, exactly.
Right? Yeah.
Right? Met or somebody else.
Right.
Yeah.
Yeah.
So then you can have new drivers, and all of those complex, like the tumor's changing, and here's different parts of the tumor and different parts of the body could have different drivers too. It's possible. So that's where liquid repeat biopsies might show you a little more perspective in what's going on. But tissue repeat biopsies are often more sensitive to figure out what's going on in one given site, because a liquid biopsy, oftentimes, it won't show anything, including the original driver, and I'll say, well, it just didn't work.
Right.
So then, does chemo work is the fundamental question, right? Chemo doesn't care about all these mutations and secondary drivers and alterations and everything else. It's going after dividing cells. So whoever's driving the fastest, it's going after those.
Exactly.
Right?
Exactly. Exactly.
It's like the slow bus you don't care about. You care about the fast bus.
Right. Yeah.
I'm trying to remember a bad movie called Speed right now.
Actually, it was pretty good. It was scary though.
So
who's
if you were on the bus.
Right.
Who's driving? I think it was Sandra Bullock.
It was Sandra Bullock.
So if you're on targeted medication for specific mutations, then does it make sense to do a round of chemo and then go back to your targeted therapy, to try to knock out some of the theoretical other stuff?
So there was actually a Japanese trial where they took patients newly diagnosed with EGFR mutant lung cancer and gave them gefitinib, an EGFR pill, for 8 weeks, and then chemo for 8 weeks, and gefitinib for 8 weeks, and chemo for 8 weeks, and it did appear to be slightly more effective than going gefitinib and then just over to chemotherapy. But what about quality of life?
Exactly.
You know, like
Exactly.
8 weeks, 8 weeks, 8 weeks. When is it? You know, what are my appointments? Like, this doesn't seem like a good quality of life, and there wasn't an overall survival benefit. It was sort of a PFS2 thing that they did. So I think this idea of doing chemo when the tumor grows after all the targeted therapies that are effective, absolutely. Like, everybody should think about chemotherapy and carefully consider it. Don't say chemotherapy is not for me. Chemotherapy can be very effective. It can get into the brain. It can work in such a different way. It sort of resets all this resistance overall. But this idea of switching or intercalating or doing it all at the same time, I'm a little less sure. You know, there's other trials emerging now, so we haven't seen the data yet, but instead of osimertinib first line, which is the current EGFR standard of care first line, what about osimertinib plus chemotherapy versus osimertinib? So this is the FLAURA2. Pasiani showed some slides. Oral presentation at World Lung, no data. It was a trials in progress. You know, it's
He's
like,
good, though.
how did I get an oral presentation
Yeah,
with no
data?
You know, it's like,
'Cause he's
here's the
Pasi.
setup
Pasi.
concept, right?
Yeah.
So
Yeah, you know, so maybe there will be something about chemotherapy plus pill therapy. First line is the standard of care in the future. But again, it's going to come back to quality of life, just like that chemo plus immune.
Can we talk a little bit about when the second marker comes involved, like an exon 20 with an EGFR mutation? When does that become very important?
Sub.
What do you mean the second marker? You mean acquired
Like an exon
resistance?
20
or
with
like
an
A
EGFR
type
mutation.
of EGFR
Right.
mutation.
Yeah, so there are subtypes of EGFR mutations that aren't sensitive to pill therapies.
Yeah.
There are clinical trials for those, some promising data now. Trials here at Stanford and UCSF also that are moving forward. So exon 20, EGFR exon 20 is kind of a special case of EGFR. It's the same driver, but it didn't care about the pill from day one.
Right,
overall,
exactly.
Right?
Exactly. But now there's a trial,
Poziotinib and
Yeah,
PAC-788,
yeah,
which we've had
yeah.
open at Stanford for a
Yeah.
while too, and a couple of other drugs in the pipeline as well. Also, chemo works, and you know, anti-angiogenics work, and immune therapy may work, and all of those things.
Yeah.
So, and HER2 is one of the other targets
Right.
too. These drugs may work a little bit on HER2, probably not as potent as the EGFR exon 20
Right.
from what
Right.
we've seen. But you know, all of these targets now, really exciting things. Maybe we could talk about RET from World
Right.
Lung.
Exactly. Exactly.
So
Do
you know,
that.
RET rearrangements are 1% of non-small cell lung cancer, very analogous to ROS or ALK. But up until now, we had tried other pills which had a little bit of activity against ALK. So one of the stories at World Lung was alectinib, which has it's approved for ALK-positive lung cancer, has a little bit of RET activity. We've tried it occasionally. The response rates were actually quite low in data presented in an oral presentation at World Lung Cancer. On the other hand, there's RET inhibitors. So one, I can't remember the name yet because it's just too long. You know, it's like one of the, it's with an E,
Right,
very long,
right,
but it's
exactly.
like LOXO-292 is the old name for it, and BLU-667 is the other RET inhibitor moving forward. And both of them seem to work in almost every single patient that tries them, plus really good CNS penetration. So another story of like the research and the rational drug development, we came up with off the bat just a better drug that's more effective, that has all those drug properties that everybody wants.
Right. Exactly. And who knew who Loxo was 2 years ago? Nobody. And boom.
Go ahead, Don.
Dr. Neal, I had a question. If you heard any data come out of World Lung, I know you're working on a trial right now at Stanford for immunotherapy and a VEGF inhibitor, and I think LungMap has one also, an arm. And I know there's drugs been around that are FDA approved, like Keytruda and Avastin, like Avastin's VEGF. Have you got any feedback around the world of are there more trials in just those two, or how well that combination is working and why it's working?
Yeah, so the trials, and this gets back to the concept I was talking about, which is I think anti-angiogenic or preventing blood vessels from coming into tumors, may be making a comeback. There's many scientific explanations that may be, or maybe we're just giving two effective therapies together. But regardless, the field is moving so that these small molecule pills, anti-angiogenic pills like cabozantinib is one of the trials that I'm working with, and also ramucirumab plus immunotherapy in the LungMap trial. And there are a host of other trials like that around. I haven't seen results in lung cancer yet. In kidney cancer, though, these are two of the only effective types of therapies that they have. So chemo doesn't work in renal cell cancer. So most of the data that I'm seeing now is coming out of the renal cell field because chemotherapy never really worked. But anti-angiogenic pills, there are 5 or 6 that are approved for first-line use in renal cell. And then immunotherapy also works and is getting more frontline approvals. So now their trials are saying, hey, these do look like maybe they're synergistic and better together. And I think it's fair to say that renal cell isn't the same type of disease as non-small cell lung cancer, but at least they're safely combined together and tolerable. And a lot of that work's been done so that we don't have to worry as much about that. Let's focus on efficacy now.
Although there are drugs crossing diseases, right, based on molecular, is it biology? I don't know.
Yeah, yeah, molecular testing
Yeah,
and
yeah,
these
yeah.
targets. And is it Eric who was talking a little bit about that, I think, earlier, right? You know, that tumor testing and the molecular target testing can be a little bit of tumor agnostic and tissue agnostic, but things like ALK rearrangements and ROS1 rearrangements are incredibly rare outside of lung cancer. EGFR is very uncommon outside of lung cancer. Some of the other alterations, MET, HER2, things like that, those are seen across multiple disciplines. And I think INTRAC is the classic story. You said who was Loxo, right?
Right,
Yeah,
You know,
exactly.
well, they're now known for
Yeah.
the FDA
Right,
approval of an
exactly.
INTRAC inhibitor.
Exactly.
Yeah.
There's another INTRAC inhibitor that just got FDA approval too, for balance. But you know, INTRAC is basically a couple of % frequency across all kinds of cancer, 0.3% of non-small cell lung cancer.
Right.
But the drug is another example of a great targeted therapy that works incredibly well if you find somebody whose tumor
Right.
has the target.
Well, I think it's exciting, sorry, just to
That's okay.
finish on that, is that for some of you who have been coming for a long time and have heard us say, will there be a day when we're actually treating cancer not based on its site of origin, but rather on its molecular, makeup, and it's starting to happen, right? And it's exciting because you're looking at, especially when you're looking at some of these smaller subsets of markers, whether it be NTRK or we talked about RET and some of these other things, I hate to put it this way because I know there's industry in the room, but I'm just going to say it. So it's sort of like one of those things, like what's in it to develop a drug if it's only for this many people, right? But now all of a sudden, if you're looking outside of this many people just within one disease, and you're able to help many more people, maybe that's a driving factor. And if we're seeing it happen, then I think that's really exciting.
Yeah, I think it's worth pointing out too, like the first example of a tumor agnostic indication was pembrolizumab, immunotherapy, for microsatellite unstable tumors across the board, and fairly uncommon in lung cancer, and most patients are going to get pembro at some point or an immune therapy at some point with non-small cell lung cancer right now anyway. But for colorectal cancer and pancreatic cancer and GI malignancies and breast cancer, like they're testing for microsatellite stability, and if it's unstable, pembro by itself can be quite effective.
Yeah. ROS1.
Yeah.
Ovarian cancer. It's in, unlike EGFR, the ROS1 marker is in quite a few other cancers. So now we're talking a pan-can issue, right? Where maybe we can repurpose some of the drugs that are being used in ovarian cancer and bring them over to lung, and vice versa.
Yeah, that's what we were just talking about.
Yeah.
Like, can you use these drugs further?
Yeah.
I want to ask, we're getting kind of short on time.
Oh, we are.
And I want to touch on something Fred said because I'm personally curious about
Fred's
it.
going, what did
Fred's
I
like,
say?
what did I say? Well, he says it. He says it every month, and Fred and I talk in between meetings, and I think he's been off his immunotherapy for a year with stable disease. Where are we with that? How is that decision made to take somebody off of their therapy and remain stable, and can you go back on? Are we looking at that?
So first of all, congratulations. That is
Right,
terrific.
exactly.
Right?
That's,
Yeah.
that's well,
I think if cancer isn't, if we say we're not sure what a cure means, but patients live 5 years without detectable cancer after having stage 4 lung cancer, we're seeing those examples now. We're starting to say, should we define that as something that we haven't seen before, but come up with a new name if we're not quite bold enough to say cure at this point?
But don't we take the Freds of the world and put them in a trial and just watch them? You don't have to do anything else. You don't have to do another thing. Just test them every once in a while and, see if a new marker pops up or something. But just watch them.
So,
yeah.
We saw some reports, and I was hearing as early as February and then again at ASCO, like they're starting to look at these long-term 5-year survival on immune therapy and say, what is it with those tumors? Now, we don't have tissue to say what was it, and now there's nothing left to detect to be able to biopsy to say what was it, you know. But these patients and the long-term survival rates, like we're hearing 15% for the original pembrolizumab trial. Long-term, more than 5 or 6 years. We heard those data at the World Conference on Lung Cancer in Barcelona, and we don't know why it happens, but it is tremendous when it does. Now the harder question is, some of those early trials said you get a year, you get 2 years, and then you're done. And so that's why we have patients who are long-term survivors without being on treatment. Are we willing to extend that to everybody else? And after an arbitrary year or two, most of those patients had a great response. So it wasn't like the stable disease or the slight progression. It was generally tumor shrinking is one of the characteristics. But we don't know otherwise. And so I think it's down to a patient decision. And we talked about these these issues.
And that's what, but I think that's what, just to, not to call you out, Fred, and if you don't want the camera to come on you, they don't have to, but Fred came off, if I'm remembering correctly, due to an itis issue, right? And so it was going to be potentially a short-term thing that he just, in a decision with his physician, go ahead, I'll let you tell your
so I mean, I didn't do it on purpose, it's just that I was developing pancreatitis. And so I was taken off, and the idea was, well, we'll give you some prednisone, and as soon as the inflammation goes away, we'll put you back on. Well, it didn't go away. And then we noticed that after 6 months, there was still no progression. Everything was very stable. So we just decided, well, let's just stop and wait for something to happen. And nothing's happened yet.
So, oh, no, something has happened. But, I'm just such a firm believer that the answers lie within the patients, and I think we have to really rethink, the trials and how we go about what we go about. And I think we have to take outliers like Fred and my girlfriend over here, who's a 100-year survivor on EGFR. What's going on? Because there are markers we don't know anything about just yet, but we're going to find them by taking these outliers. The people that are responding amazingly well, but also the ones that progress really fast. There's answers there. And I don't think it's always about a 3 or 5 year trial. I think we can learn a lot in a year just by gathering information about these particular people.
So the question of whether to stop immune therapy after a year or two, I think that's still an open question. And in our cooperative group, I go twice a year to a big meeting of a bunch of academic investigators, and we decide what are the big trials that industry might not answer. And one of the trials we thought about doing was a kind of discontinuation of immunotherapy versus staying on to see if there is an effect.
From a patient perspective, that feels like such a scary thing.
It's so scary, right? Nobody's going to want to be randomized to that, right?
Right, exactly.
But at this point, knowing what I know, I think I would support either option. If there's any reason that a patient has to say, I want to stop the immune therapy after a year or two of having very stable disease or a good response, do it. Most of my patients that have been stopped have done so because of an immune-related side effect. And there seems to be that the patients who have immune-related side effects and a good response do have more durable responses.
Yeah.
So I often do that too, where I don't restart it until we see growth.
Yeah. I'd be
so we don't
watching
know.
Fred and taking blood tests on him like every 6
Well,
months.
and I think
see
this is
something
where
pops up.
big data comes into play on some level, in my opinion. If we can take patient-reported outcomes, if we could get EMR to talk to one another and be able to pull true data from there, and pulling data from these other places and start to find these commonalities, even if they went off it by accident, what can you see there that might create this like aha moment, right?
Yeah.
Which is what is super exciting to me. Go ahead, Fred.
Yes, one last point. That's why I'm on the Natera study.
Yeah.
Because to me, if there's a progression, I'll know about it a lot sooner if what they are trying to accomplish is in fact going to work.
Yeah.
And I think so far, that it's about 6 months ahead of a PET scan. That they can detect progression. So I have a vested interest in that study.
Yeah, that'll be very interesting.
I
want to
Go
point
ahead.
out one more thing. For targeted therapies, I don't think it works the same way, and I think it's better to stay on the targeted therapy. 'Cause
Absolutely.
if we think about that heterogeneity and we say 99% of tumor cells, the brakes are on right now, keep the brakes on.
Right.
Right.
Absolutely. Absolutely.
This has been such a great living room because I think the conversation happened 100% organically and came from you guys and what you were asking and questions that led other people to ask questions. So I loved it. I didn't have to hardly put my glasses on and look down at what
That's awesome.
we were supposed to talk about at all. So thank you all for your questions, for your engagement, and everything that happened tonight. Thank you so much to our dear friend Joel Neal. He's clearly not just our friend; he's everyone's friend. And if he thinks that we are not going to create a PSA and send it over to you, you're 100% wrong, because we're going to do that. We're going to send it. We're going to send it down the street. There's a couple of housekeeping things that I want to go over before I end with. I'm going to let Sally do a little bit of talking before I finish my housekeeping. But Thursday, so Michelle and I are flying out to Toronto tomorrow morning. Thursday, 5:30 Eastern time, so 2:30 here. We will be hosting another living room at Princess Margaret Cancer Center with Dr. Francis Shepard and Dr. Natasha Leal. It's going to be a really, really exciting thing. It's going to be a little bit different for us, not only doing it in another country, but Dr. Neal and I were talking about this a little bit earlier. Another country where standards of care are different than they are here, right? And so what that is going to look like and kind of feel like is going to come from the perspective of how they treat lung cancer in Canada. So anybody who wants to tune in, please feel free. You want to talk about Francis's award?
No. We gave Frances an award, a while back at Lung Cancer Congress, but she's amazing. That's not what I wanted to talk about. I wanted to talk about this is so huge for Lung Cancer Canada, because they don't have access to what we have access to here
yet,
and we're constantly helping them, fight, the access issues in Canada. This living room in and of itself is going to be recorded, and it's going to help them get access to more opportunities just because it's happening and it's being filmed worldwide.
It's pretty cool.
There.
And then September 28th, I know I mentioned this last time. Most of you know Francis Spruitt. He could not be here today, and I didn't staple it on here, but Wine Hard, Breathe Easy is happening. I have flyers somewhere. Michelle, there's flyers on the table out front. So that's September 28th. I believe it's at 6 or 6:30. Francis, I'm so sorry, because I know you guys are watching. Congressman Mike Thompson from California District 5 is going to be attending. So that's
He's
awesome.
a big guy. He's a good guy.
He's coming out to do that. So we're excited about that. October 15th, back here, living room, Dr. Gandera from UC Davis. You guys have all seen him here.
And you're invited to come. Well, thank you.
Come and sit.
You can come anytime you want. You can be in the audience, and you can be the one asking all the questions.
What's the date on our...
I don't want all of my patients to upstage Dr. Gandera. That wouldn't look good for me. So.
Sally, what's the date on this event? Sorry.
October 13th.
Okay, perfect. Go ahead, you can talk about it.
Oh, well, I did send out invitations via email to everyone that I had an email address for. We're the Lungfish Society, which was started by Tina and myself and joined by Danny Gasparini and Sheila Vandriska. And it's just for us to all get together and have a good social time and not be talking about lung cancer and all the medications and so forth. So we had a wine tasting several months ago, and this time it's going to be a bingo. And if you'd like to bring an hors d'oeuvre, an appetizer of some sort, we'll be providing wine, and we're asking for a donation of $10 for 3 bingo cards. It's not necessary, but if you would like to do that. And if you could let me know by hopefully October 1st, that's what this says. And anybody who didn't get the email, please take one. We printed some and put them out. And also give me your email address so I can invite you for future things. And like we have lunches a couple of times a year, which we're skipping this fall because we're doing this instead. So I hope that you'll all come and be a part of the Lungfish Society.
Thanks, Sally. And then I'm going to speed through the rest of this. October 17th, Michelle and I again, and David Leduc, who I think has been on Facebook tonight monitoring the session, as well as one of my colleagues, Maureen Rigney, are going down to Mexico City to hold our living room there at the Latin America Lung Cancer Conference. So that's really, really, really exciting. And then events coming up. We already talked about our San Francisco 5K here, September 22nd. For all of our friends in Philly who are watching, October 6th, a lot of us will actually be there at that Philly event. So please, 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 if you haven't created your team and signed up and done that, Philly, October 6th. And then on November 2nd, we're in both Hollywood, Florida, and Houston, Texas. So all of our Florida and Texas friends, please, please, please come out and spend a day with us.
Yeah.
Super fun. A huge thank you to our patients again. I know I said this at the beginning of the meeting. Caregivers, friends of lung cancer, everybody in the room, for sharing your stories tonight. I say it over and over and over, and I feel like I repeat myself at every meeting, but you can't imagine what it means to the people watching online live and those that will come back and watch later to feel part of a community, even if it's virtually from their home. So thank you for allowing us to film this, for sharing your stories, for asking your questions, and being such a huge part of what we do. Huge, huge, huge thank you to Dr. Joel Neal for coming down again and talking with us. Of course, none of this would be possible without our supporters, so this I do need my glasses for. So Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Celgene, Dignity Health, Foundation Medicine, Genentech, Lilly, Medtronic, Merck, Novartis, Takeda, and Tesaro. Thank you, thank you, thank you for all your support. We could not bring this to everyone without it. The very last, but the absolute not least thing I want to do is wish a very, 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 hurry up, Katie, happy birthday to our own Sally Samuels. So most of you in the room know Sally. Most people online know Sally. Sally has, as she stated earlier, been coming here since the very first living room and even before that.
Which was 10 years ago.
To the 5K, yeah. Sally's been a part of this organization pretty much since we opened our doors. She's an amazing volunteer. She is one of our dear, dear friends, part of our extended family, and we want to make sure to wish you the very, very, very happiest of birthdays. So if you'll all join me in wishing Sally a happy birthday and singing. I'm not going to sing into this mic. So on your mark, get set. Somebody, Katie.
Birthday to you. Happy birthday to you.
Happy birthday, dear Sally. Happy birthday to you. Woo! And that's it. Thanks, everybody. Thank you online for watching. See you guys in a couple of days.
Thank you.
I know you can get mobbed.
be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.